Welcome back. How are you feeling so far? Yeah? You're not depressed, let down about the state of science? There's an ombuds person here if you do want to talk. And actually, I forgot to mention that room 302, right, is around the corner to the left across from the FedEx office, just in case anyone wanted to get over there and talk about how depressing this morning's sessions were, or how provocative they were, and you wanted what are you going to do with the right questions and how to answer them. So now we're going to pivot a little bit, as you can see in the program, to something that obviously has a lot of attention these days and a lot of focus: neuromodulation or spinal cord stimulation. And I think we've put together 3 presenters kind of in very different areas, but underneath that umbrella. And the first one is Dimitry Sayenko from Houston Methodist, who I think you'll appreciate. I've known Dimitry for a little while and really appreciate the way he thinks about this space and his approach. Please welcome Dimitry.
Hello, everyone. Everyone can hear me, right? Okay, the clicker. It's quite unusual for me to present without my laptop, and behind which I can hide a little bit, but also look at you. Okay, so my name is Dimitry Sayenko, and I work in Houston Methodist. And I've been in the area of neuromodulation for a while. And then we had this moment with Matthew where I expressed my hesitation on at what pace we have to try to commercialize and bring the approach to the consumers. And I think that was all overall very positive conversations, right? So I forgot to put the true in wheel symbol here, because this is what we were talking about, that probably the truth is somewhere in between. And then each of the sides, such as researchers, engineers, businessmen, and consumers, have to pull in a certain way so that we have a balanced wheel rolling to help those who live with paralysis. Well, as you can see, that the title of my talk is determining, well, I mean, part of it, determining the right fit, which reflects or resonates with the point of is this the approach which one size fits all? So let me try to elaborate what I mean. So the spinal cord neuromodulation runs under a few premises. One is that there are still connections, subfunctional connections, but they exist in the spinal cord after the trauma or conditions. Even if we have signs of complete spinal cord injury, Asia A, there are still, like in 80% cases, there are still those tissues which we can, existence of which we can leverage to promote a function. And my friend and colleague, Juliana, put very nicely, formulated very nicely in his review, in our review, how spinal stimulation works, or spinal neuromodulation works, which is the premise that in the intact spinal cord, we have connections, circuitries, which which communicate with the supraspinal or brain centers. Also, they are receiving signals from afferents, from the periphery. And if everything is working normally, then we can initiate certain movements, or we can initiate certain activities, rhythmic activities, which are fed by the continuous afferent signals. And then we can just keep things rolling. In the presence of spinal cord injury, though, the connections between the brain and those networks is lost. So we cannot initiate the command, we cannot initiate the movement or activity. And even though there are still afferent signals come to the circuitry, it is still, the output would be still disorganized and functionally irrelevant. And what spinal stimulation does is that pre-activates or changes, I would say, the excitability of those networks below the lesion so that they become susceptible to the descending commands, and then they also even, in the presence of periphery signals, we can get more organized, more functional movements. And several years ago, during one of Asia's symposiums, Becca and Megan and I came to this idea that how to demonstrate, how to visualize those effects of spinal stimulation. So after spinal cord injury, the expectation of increased performance is pretty low, right? And even with time and with intensive training, the performance may still be at a very low level. However, in the presence of spinal neuromodulation, we can increase this level of performance, bump it up really, and then we can try to build new skills or new performance with time. And what's happening actually, what also we saw is that with time of training, the amount of neuromodulation can be decreased. So the responsiveness of the system would be still there. However, the amount of, let's say, electrical current would be decreased. And then there were a few reports which showed that even spinal stimulation can be off, and we will still have this very high level of performance, which we didn't see before that. And this is one of the happy examples which was a result of my collaboration with Mayo Clinic. So there was a joint group, UCLA and Mayo, where we replicated some of the studies in Louisville, and we saw immediate restoration of the function, great performance in terms of standing. And then, and then even we could see that after 40 weeks of training, we were able to achieve self-assisted locomotion. And this is one of those very happy moments and very happy stories, which I think a little bit overshadow the reality, right? Because I was just texting with my friend and colleague, Peter Grahn, who was one of the leads in this study. And I said, like, do you think that I can tell actually the truth? And he's like, oh, no, this is not like, it's not a secret. Everyone knows it. But how many of you know that there were actually 2 subjects in Mayo Clinic and only 1 is reported in Nature? So there were 2 people studied, they overlap significantly. And this is subject 1. And this is what we achieved. And that was great. But there was a second subject who was trained and underwent absolutely the same therapy. But the maximum we were able to achieve is somewhat improved standing and 1 leg independent stepping on a treadmill. And then after a while, that person was quite upset that he was not able to achieve the performance of the first subject. So he withdrew himself from the study. And this is the reality that we are dealing with, right? We know only well, many of us know just the bright side, how spinal stimulation works and how it is effective. But unfortunately, in this at least case, it's 50-50% chance of a great success. And I saw this as well with transcutaneous spinal stimulation. And here are the examples of 2 persons. On the left, there is a great performer. He was absolutely outstanding. You can see how independent he is in the presence of transcutaneous spinal stimulation. Let me turn it off again. How his muscles are firing. He's standing surprisingly independent, and it was obvious at the first time we start working with him. And on the right, there is another person. He has a little bit different body composition and level of the injury, but we had 12 sessions with him, and he still couldn't stand independently. So 1 leg, 1 knee was kind of there, fully extended, but then he required quite significant support to another knee. So this steered me to submit a grant, and we worked together with my friend and colleague, Kei Masani from University of Toronto and Toronto Rehab, where we said, okay, well, can we boost it up a little bit? Can we supplement this deficits and stand-in? Can we apply spinal stimulation and peripheral muscle stimulation to improve the function? And our results, that was our first subject. She has a complete A injury. And then in the presence of TSS, only spinal stimulation, she was able to stand quite well. But then once we started stimulating her plantar flexors, she was absolutely amazing. Also, I have to brag here a little bit because the device which you see on the left was developed in my lab, and it allowed us to very well quantify the effects as compared to our approach in Mayo Clinic several years earlier, where it's just two therapists were kind of providing feedback on what kind of performance we have in. And this is another subject where we apply the same approach. You can turn off the sound. So there are three examples when he stands without stimulation, with spinal stimulation only, and then when stimulation is supplemented with spinal stimulation with muscle stimulation. And you can see certain, like especially on the right, on the very right, you can see very outstanding performance. And but it is also, it's not the happiest story, right? So the first subject demonstrated much better results. So we were happy, he was happy, but still, to me, it's everyday recognition of huge variability of the effects, and that even though we apply the same approach, we believe that it works the best we can, the best we could expect, there is still discrepancy and there is still variability in the outcomes. Then we decided, okay, well, apparently two works better than one, so let's combine and let's see what's going to happen with combination of more technologies. So we would use spinal stimulation under the premise that it will amplify the signals in the spinal cord, provide better connection with descending drive and with afferents, and then robotic exoskeleton would provide us this continuous repetition and multiple repetitions, those kilometers of activity of rats in cages, right? So because apparently the more you do exercise, the better. And we realized that we can also harness, so even though we apply this together, we can still do even better. So what if we would we would compare the effects of tonic stimulation above the spinal cord, the approach which is most commonly used, and combination of pattern stimulation to promote different movements. So we run both tests with exoskeleton, and before that, we even try to elucidate the effects and see if we can fine-tune it without exoskeleton to promote the specific patterns of motion and activate different muscles. So I would like to invite you tomorrow to hear Valerie's presentation, because Valerie Dietz, who is a postdoc in our lab, will present some of these results. But for now, I'll just show you the effects of tonic stimulation. It's two left videos, and the pattern stimulation. And this is a person with AGS-A paralysis. You can see it's a chronic paralysis. His legs are quite atrophied, the muscles, but the amount of motions is quite different. So even within one subject, applying different patterns of stimulation would result in very different types of activity and different level of functional performance. Okay. And then we thought, okay, so Combination of methods matters, patterns of stimulation matter, but we also see very different effects of stimulation in the presence of other signals within the system. So our question was, would we be able to investigate this interaction between descending drive and spinal stimulation? Maybe this is the key. Maybe this would provide us different results as well. And we used a large animal model, Yucatan pigs, where we implanted the array above the lumbar-spinal cord, and we provided cortical stimulation to see to understand the effects of this communication between the signals. So that was intact animal and fully anesthetized when we stimulated the brain and we stimulated spinal cord. And the idea was that we would provide periodic pulses to the brain to get the motor evoked potentials in the hind limb muscles. And you can see the traces. So it's like there a bit on the right from the red arrow. These are very tiny evoked potentials from the brain stimulation. And then while we were providing this brain stimulation at a quite low frequency of 1 Hertz, we supplemented and we added epidural stimulation at 30 Hertz, with the idea that once in a while, those pulses will collide, and with the proper timing between those two pulses, we will see facilitation of the effects. So both of these stimulations were within the same frequency and the same intensity. I mean, like at each stimulation level, right? And then you can see that with the, again, proper timing, the facilitation is huge of those descending impulses. So the evoked potentials in the hind limb muscles increase significantly when it's a proper timing between them. But also we were trying to run other tests where we varied the intensity of epidural stimulation. And this is what we got, that intensity of epidural stimulation has huge effects on how they will facilitate the descending command, with the most significant effects up to 400 times increase of the responses when epidural stimulation was reaching motor thresholds or close to motor threshold. So not too low, because then there will be very little facilitation, not too high, but it has to be a proper dosage of that epidural stimulation to get this very dramatic effects. While I'm telling all of this, so like it was rapid fire, I apologize about too many things to digest probably, but I would like to just draw attention that there are lots of things that we know, but there are, of course, more things that we don't know. And we understand, we see the enabling and inducing effects even after very severe paralysis. However, it is absolutely no doubt, there is no doubt that the extent of those effects depend on the combination of the technologies, on the type of the technologies delivered, even the intensity of stimulation, and of course, the neurological status, level of fitness, body composition, and other factors that are relevant to each particular individual. So coming back to where I started, the 50-50% effect is very common, and I expect it. I'm learning to live with this, although it takes long time to go these little steps to keep publishing even, and then it is hard to feel sometimes myself in the shadow of those very big Nature publications where they demonstrate that, oh, well, now it's working. We find the cure. Well, we got the neuron working. And to me, I'm still probably at the position that we have to be very, very careful when we push the product to the users, understanding that not all of the users would be benefiting from it. And the most of all, my fear is to let the consumers down, to understand, okay, well, we've got it. Here's the product. But then when there will be perception of, well, but it's not working, or it's working in 40% chance or 50% chance, while in the best case scenario, 70% chance. I really don't want to be one to blame and for raising false hopes or overpromising or overselling certain approaches. And then also, I would like to come back to my very initial slide. And for myself, I reconsider these schematics, right? So this looks absolutely beautiful. Spinal neuromodulation bumps up the performance. However, what I recognized that there are so many cases when the performance is very different between the subjects. And then sometimes it's just a linear progression and there may be no improvement at all. So I just would like everyone to be on the same page and share these thoughts and reflections with me. So that's pretty much it. This is my group, whom I'm eternally grateful for support of our research, granting agencies. And by the way, we are recruiting subjects for our NIH-sponsored funding for transcutaneous and epidural stimulation effects. Thank you very much.
Thanks, Dimitry. Much appreciated. Keep that last little bit, especially in your mind, for the panel discussion, as we will have a discussion. So now I want to introduce and I give a little preface too, so you remember Jen Doolin's slide earlier today about some of the gaps in funding, and one of them being sexual function. And if you'll look at our last several years, we've been really trying to go out and identify folks that are doing sexual function studies, sexual function research, and incorporate them into the agenda because it's important to our community. And so we've been trying every year to do that. In this case specifically, as Elizabeth comes up, welcome Elizabeth, is over the years, somewhat related to what Dimitry just said, there's a lot of anecdotal reporting on sexual function improvement in epidural stimulation or spinal cord stimulation studies. But there's been a lack of investigating that. So there's a lot of anecdotal, oh, well, some people had return of sexual function, but nobody was actually seeking that as an aim and an outcome that they were measuring. And so here comes Elizabeth as an add-on to the East End trial, University of Minnesota. Please welcome Elizabeth Bottorff.
Thank you, Matthew. All right, so we're here to answer this question. Obviously, I'm not going to be able to answer it really, but I can tell you what I think and basically share what I know about this topic. So this is going to be kind of more of an educational session, maybe, in part at least, because I just want to make sure that we are all understanding of the terminology that we use. And so I'm sorry if I over-explain anything, but given the state of sex education in America, I think it's important to just get it out of the way. We're going to talk about the current available treatments and therapies for sexual dysfunction after injury. We're going to briefly talk about epidural spinal cord stim, but since Dimitry did such a good job, I'll have to explain a little less. And then we'll discuss the results I have so far, and then we'll talk about the challenges, limitations that really affects my research, but like all of sexual function research in general. So as we know, there's that Anderson paper again. Sexual function is a very high priority to restore after spinal cord injury. That's because sexual function and life satisfaction are intimately tied together. I agree with the World Health Organization when they say that sexual health is a human right. And I particularly like this quote because it has the word pleasurable in it, right? So I'm talking about sex. I'm not talking about fertility. I'm not talking about reproduction. I'm talking about sex and the pleasure that it provides and what that means for people. So if you're ever in doubt or, if you feel like anyone is invalidating you, it's a human right. It's a healthcare problem. Stick up for yourself. So let's go through the basics. This is a slightly outdated but very practical sexual function model still. This one in particular was designed for women, but I like it because it shows the typical stages that you go through in the sex response cycle. So you usually start from a point of sexual neutrality, and then you'll be presented with some stimulus. Maybe something touches you, maybe you see something. And you might not even consciously be aware of it, but your body's kind of like, oh, okay. And then you start to get this feedback loop as you progress through the circle, right? And so by the time you get to sexual desire and arousal, those are very key components of the sex response cycle because they're what provide the positive feedback to keep building and building and building until theoretically, you achieve orgasm or you're done having sex. And so without that component, you can see how it's hard to keep building the blood flow where you get to a point where you're going to have intercourse. You need the blood flow, right? The penis needs to be erect. And for women, what that does is it engorges the vagina, the vaginal canal lengthens, and it produces lubrication so that you can have painless sex. It's a very key point in the cycle. One of the reasons I said it's outdated, and I'll touch on this a little bit, current sex psychophysiologists really like this new model. It's called the sexual tipping point. And what's nice about it is I agree, it still starts at a place of neutrality, right? But you can have all these different factors that push you to and away from wanting to engage in sexual intercourse or being sexually receptive, right? So there's your typical physical factors that I think of as a biomedical engineer, anatomy, hormones, genetics, spinal cord injury. But there's also mental factors, right? There's your relationship status, the cultural norms that exist in your society, your emotions that day. And right now, a very popular theory about a way to picture sexual desire and sexual receptivity is you have brakes and you have accelerators. And so you're still being pushed and pulled back and forth from these point of neutrality, excitation, etc. So I'm not going to be talking about this a lot, but the reason I bring it up is because these are things we need to exclude from our analysis, okay? We have participants who are like taking forms, right? Because that's one of the best ways that people measure sexual function. It's with validated forms. And so what happens if one day your participant comes in and her sexual function score is just so good and you're like, wow, was your like stimulator setting just really good? Like, no, I had a new partner. Well, did we ask that on our forms? Like, I don't know. How do we rule that out? So here we are thinking the stimulator did it, but she just changed partners. So they're just very important things to keep in the back of your head and control for. So how does spinal cord injury affect sexual function? People with injuries, I hope you have been shared this information before, but as I'm finding out, sexual education, sexual function healthcare for people with spinal cord injury is honestly not even talked about. I have a couple of lab rats that Matthew and Unite to Fight generously linked me up with, and they both said that a doctor has never asked them about their sexual function and they've been living with their injuries for decades. So that's rough. What I can say generally is just like many other things, it really varies, but there is a general rule of thumb where if your injury is below T11, you retain reflexogenic arousal. So what that means is you become aroused, you get blood flow in response to touch. Okay, below L2, you're more likely to retain psychogenic arousal, which means you're becoming aroused because of thoughts. Dirty thoughts, porn, image, anything like that. They're different pathways. There's the typical way spinal cord injury can, not typical, but the obvious, right? You lose sensation, you lose arousal, you can't have an erection, you lose blood flow, so no lubrication. A lot of people lose orgasm, some don't. A lot of women, even with complete spinal cord injuries, they're able to achieve orgasm. It just takes them longer. We don't know why, but it's documented at least. And of course, ejaculation. And then I just want to touch on these other complications that are a little tangential, again, important to kind of keep track of, but not necessarily like my outcome of interest. So there's psychosocial implications, libido changes, but that is not necessarily because of the spinal cord injury. It could be because of like what you're going through. Your interpersonal relationships change, your self-image is different, and then there are secondary complications that more or less interrupt the actual act. I've talked with participants where autonomic dysreflexia is triggered by sexual activity. Luckily enough, she turns her stimulator on and she doesn't have it anymore and she's able to engage in sexual intercourse. So like Matthew said, another very cool anecdote is that anywhere on a survey or a paper where I could put a number and publish? No, I just have a story. And obviously, spasticity, loss of bowel bladder control, you can see how that would interrupt the mood. So treatments and therapies, a lot of the therapies that exist are just the same ones that are available for able-bodied people. So here we have Addy, it's the pink pill. People are trying to market it as the Viagra for women, but it's not because it's a drug that improves libido. So is Vyleesi, again, another drug marketed for women, supposed to improve libido. You're supposed to stab yourself in the leg 30 minutes before you want to have intercourse. And then, of course, there's Viagra. That can certainly work. It's, not designed for people with spinal cord injury, but ultimately the effect is still to like rush blood everywhere. So it does help with erection a little bit. There's devices. So the first device is an electrojaculostimulator. It's actually for reproduction, but they'll use this with men to try to retrieve sperm for IVF. And then there's this Eros suction device. The male version is a penis pump, right? And these are devices you can use to, at least not pharmaceutically, like enhance blood flow to the region, trying to get any sensation you can out of there, and hopefully at least like produce an erection or lubrication. And then there are behavioral modifications. You can find out what sex positions work better for you. Lube, there are so many different types of lube now. Sometimes they come with like CBD. It's like I go to these conferences. It's a crazy new world. So I'm sure there's something out there for you. And avoiding food and water intake before you engage in intercourse. And then, of course, if you ever want to talk to like a primary care physician and get referrals, these are the people who should be able to help you. So where I come in, I am a postdoc at the University of Minnesota, which is basically means I'm kind of like a resident. It's just more training after my PhD. And so I'm part of the ESTAN trial that Matthew talked about. For those of you that are unfamiliar, basically what they do, they've recruited people with spinal cord injuries of varying levels between C6 and T10, and they implant this epidural stimulator. You can see at the T12L1 level, and that's because that's where the nerves that innervate your legs exit the spinal cord. So the goal of this study is to see if epidural stimulation alone, like no rehab, can improve volitional motor outcomes. This is not to say that we don't believe in the value of therapy. We really believe in the value of therapy, but as scientists, we are just curious and learning what is the instantaneous effect of stim turning on. And we're finding some very, very cool things. So please play.
All right, right leg up, down, right leg up.
So you can see
Down.
she's following his controls
Right
pretty
leg up.
well. And this is day 2 after
Down.
surgery. No therapy.
Right leg up, down, hold it, stop.
And so you can imagine if you gain a little bit more
Right leg up.
movement, what
Down.
other rehabs you might be able to add on to this.
Try to not move your body.
Who does that a little
Yeah.
more, but basically
Okay, I
during
wanna
this
isolate it.
study,
Right
they
leg up.
found that there were some sexual function benefits, right? There's some of the anecdotes I've already shared, and then they also take what's a few validated sexual function surveys. So, they get their implant, they do a series of baseline assessments. They come into the lab, they get the surgery, they repeat the assessments, and then they come back once a month for about a year and repeat the assessments. And so these are some of you can see the baseline visit and the post visit, which is actually just their last visit once they've done a whole year of the study. And so this is the results for 3 women. The top, I can read them off, but the first one is very noticeable, a female sexual distress scale. You can see that decreased significantly, which I think is our most interesting result. But we're seeing mixed reviews along some of the other domains, right? So this is just a 19-item questionnaire, and you can break it down into different domains to try to understand what's changing, not just sex. So it breaks it down into arousal, pain, orgasm, desire, satisfaction, and lubrication. I want to draw your attention to D, which is the pain domain. Right? They all scored very well. Higher is good for those. But they have spinal cord injuries. They have different types of pain. I guess they have no neuropathic pain. But the way some of these questions are phrased, it kind of penalizes you in certain ways for having a spinal cord injury and other ways. but I won't get into that right now. We saw similar results for the men. The men did the International Index of Erectile Function. But again, like what's changing? We just know that scores improve. That's not really enough to like gain understanding of what's changing. Why is it spinal cord stim? Okay. So I have designed this e-stand addendum. For the women, we use the laser speckle contrast imager. It's basically just a camera, and you aim it at the vulva, and you get a blood flow reading. The penile photoplasmography device is basically just like a strain gauge. It goes around the shaft of the penis, and when the penis becomes erect and engorged, obviously some strain is produced, and we can measure that. And so what we do while we measure those two indirect, I would say, measurements of blood flow, we're also asking participants to rate their level of subjective arousal. So what we do is we just ask, okay, how turned on do you feel right now, right? While they're watching a series of movies. So we start off with a baseline movie, it's about 5 minutes, an erotic video, varying lengths around 10 minutes, followed by a neutral video to ideally see the blood levels come back down to baseline. So we record all this continuously, also with heart rate and blood pressure, trying to basically capture the effect of stim, and we hypothesize that it will increase when it's turned on. So we do the entire 25-minute trial with stim and then without stim, or a randomized order. So far, we've had one participant, and she's come in for 2 sessions, so I don't have any strain gauge data to show you, but I will be able to show you what the laser data looks like. So this is the image of a vulva. This is just an example of the readings we get. You'll see in a neutral video, less blood flow, erotic video, more blood flow. We'll draw regions of interest around different anatomical landmarks, like the clitoris or the inner thigh, or maybe like right on the labia, depending on our camera angle. So we're gonna be looking at that data after I draw the regions of interest. So here's one trial. This is an example of what they look like, and you'll see the baseline, the erotic, and the neutral videos. And what we do is you can see there's a blanket lying across their lap, which is what the blanket is. So we have kind of like a neutral reference point for if they move. And so we'll use the blanket to try to identify the movement artifact so we can clean it up, and then we average the values and just compare them between the different videos. Here's the results from the 2 visits. So each visit is 2 trials because one sequence is with stimulation on, one sequence is with stimulation off. And I just want to walk through this plot because what this does is it shows you a good example of what we're looking for. 8% increase from baseline to erotic, and then no significant changes, right? This is kind of we expect to see. We want to see an increase with the erotic video on. What this means is she has retained some level of psychogenic arousal. Next one, up 3, down 17. This we definitely expect to see because in most individuals, your blood flow levels return to baseline, so you can kind of go again. People have varying opinions on how long that takes, which is kind of muddying the data, but that's what we like to see. For her second visit, we did stimulation on first. We see negative 6% decrease and then no change. Is it because of stimulation? I doubt it, because in the other stim session, she went up 3%. And in this last session, down 11, down. I can't tell you why, but this is a little more worrying, especially because she already demonstrated some capacity for psychogenic arousal. So what could this be? Is it because she is watching the videos for the second time, even though they were a month apart? Did she have a different partner? Was she recently sexually active, so her body isn't ready to let go again? There's so many variables. And so what we need to do is just test way more women. So this is what I have now. We're still recruiting. One of the challenges I face is that I recruit through eStan. You can opt into my portion of the testing. What that means, though, is that in order to participate in my study, you have to qualify for eStan, which has more stringent criteria. So in the future, I'm working on a protocol where I could enroll a broader variety of injury levels and completeness and healthy women so that we can control to a more representative baseline. Because again, maybe not again, this is a relatively new device being used in this way. So no one has ever used it before. Okay. Talked about this a little bit already. Variability of injury, huge. You know this. How translatable is this methodology? Well, the way I described it, hopefully you got some sort of like picture of, a person sitting in like a lab chair and they're in a very clinical setting. And like, this is not how humans have sex, right? Like, this is not, people will often comment and they'll be like, yeah, this room isn't very, I'm like, I know, I'm not trying, gotta keep it professional, but you do want to mimic real life, right? So I just think it's important to really, like, this is important work, but you really have to consider how translatable this is. If this is going to increase blood flow, I'm going to say, yeah, this will increase blood flow, but I'm not saying it's going to just like translate to the bedroom. We don't know yet. The taboo nature of sex has led to a lack of common language. I've, been reading these papers. There's so many anecdotes. They're like, sex improved, or what's wrong? I have sexual dysfunction. I'm like, that's so broad. I have no idea how to help you. Do you want to ejaculate? Do you want to orgasm? Because they're not always the same thing. Do you need lubrication? Is it blood flow? Is it erection? Is it intimacy? Is it self-satisfaction? Is it just pleasure? Is it boredom? So it's hard to communicate about these things with, strangers. But I think the more we talk about it, the easier it becomes. At least for me, it certainly has. And then there's funding challenges. We talked a lot about this morning. For sexual function research in particular, I had a conversation with somebody at the NIH, and I was like, okay, if I wanted to fund this, which branch? I think they're called branches. Which branch should I go to? Should I go to NINDS, which tends to do, spinal cord injury research? Should I go to NIDDK for men's sexual health because they do kidney, which is urinary? But if you want to look at women, you have to go to NICHD, which is childhood development. Again, not related to pleasure by any means. So it's a tricky question. Dr. Biden put forth a women's health initiative, so I'm kind of hoping that will help get things moving along because there's a lot of low-hanging fruit, right? I don't need millions. I don't need the kind of millions that like you guys need for your crazy invasive brain imaging and all that. Like, I don't need that much. I really don't. It's pretty simple stuff. No one's just bothered to try and figure out yet. So there's those challenges, but we've been able to make it work so far with some smaller grants. So how can we further the field? I'm going to skip the history of sexual function research, but I do want to highlight that we've been talking about animal studies. What I've noted a lot is that they will often just study men or male animals, and then they will extrapolate to women, which I think is very unfair. Governmental emphasis on reproduction, I already talked about that. How can you help? Just talk about it. Let's start easy. Just talk about it. Normalize it, validate it, just ask. And I think you'll notice a very positive response. With that, I'd like to thank Dr. David Darrow and Sam Kramer, who are PIs of the Restorative Neurotrauma Lab, Tara Nash and Nidhi Satish, who support that work, and Drs. Tay Nedoff and Matt Johnson, who run the T32 that is supporting me. Thank you.
Thanks, Elizabeth. Oh, there he is. So next up, right here in Atlanta, at the Shepherd Center, Evan Sandler is going to talk about the use of transcutaneous stimulation to address spasticity.
Yeah. Is this thing on?
Welcome.
Oh God, I'm loud as it is. So if it gets too loud, just somebody raise their hand and say, shh. So I'm really, really excited to be here today to talk about, oh God, I'm going to touch myself. That's not going to work out. My dissertation work. Currently, I'm in the last semester of my PhD. And my whole focus as I was a clinician at Shepherd Center was to be able to address some of the issues that we see in the clinic that might help make therapy a little bit better for our patients. And now I get to work with participants who come in usually on a daily basis and try these new innovative technologies to help things that really affect their daily lives, spasticity being one of them. So Dr. Sayenko talked about the volitional control. We see a little bit of non-voluntary activity from sexual function. And now I'm going to talk about the involuntary muscle spasms that people with spinal cord injury may experience. The issue is there's two ways that we can talk about this. There's the clinical presentation, what we can see, and there's the reasons why we get to the clinical presentation that we see. So what are the mechanisms, or what is just the presentation itself? And so today I'm going to try to help link the two, or talk about what possibly links the two together, and can we expect them to be linked? The research that I'm going to present is funded by NIH, an R01 grant, and I am actually funded by the Jack and Dana McCallum Neurorehabilitation Training Program at Georgia Tech. A group of very well introduced to spasticity individuals came together at the Spasm Consortium and created this new definition of spasticity that not many people widely understand or know in terms of in the physical therapy world, because it's not something tangible. They identified disordered sensorimotor control resulting from an upper motor neuron lesion, presenting as intermittent or sustained involuntary activation of muscles. And I will say most of our participants and people with spinal cord injury, when you ask them about their spasticity, they talk about stiffness. I'm stiff in the morning, I'm stiff at night. It just feels like I'm stiff. And that's the involuntary, sustained involuntary muscle activation that you can see in the EMG at the top line here, and then on the quadriceps and the soleus. However, in research, it's really difficult to measure that. So the clinical manifestation that we can measure most easily is hyperreflexia, or like a tendon tap when you go to the doctor. And spasticity most widely is recognized as a spasticity, an increase in velocity-dependent tonic stretch reflexes with exaggerated tendon jerks resulting in hyperexcitability of the stretch reflex. So this is kind of what it looks like on a pendulum test. I'm going to show you two videos, one on the left and one on the right. So we have somebody semi-reclined, a participant semi-reclined, relaxed upper body, and we hang their leg over top of a plinth, just like this. So the leg is extended and it drops. Now, those with neurological injury, you might see a catch or clonic activity. But for individuals who are neurologically intact, you normally see it drop and just swing. So on the left, you see somebody without neurological injury. It swings, it may oscillate a few times, and then it comes to rest. On the right, you see somebody with spasticity, where there's that catch, and you might see a few clonic beats before it relaxes. And that's one way that we can measure hyperreflexia. Most spasticity measurement falls into two categories, the biomechanics and the electrophysiology. In the electrophysiology world, most of the time you use an H reflex. So the electrophysiologic or the electrical equivalent of a tendon tap. In the biomechanics, we can do what I just said, the pendulum test, or the ankle clonus drop test, which is an analog to the pendulum test, but at the ankle, where you raise a participant's leg or lower leg above a specified height of a platform, you raise it to a specified height, you drop it, the forefoot contacts, and you might see some clonic activity. The question, though, is whether or not these two things might be linked. So in our lab, we had a PhD student who performed a systematic review, a scoping review, actually, and identified that it's a mixed bag. Sometimes they're associated with each other, and sometimes they're not. So spinal excitability measures of spinal excitability in terms of H reflex might not reflect what you see clinically in terms of the biomechanic presentation. So then we are introduced to something called posterior root muscle reflexes. So I want to introduce this as another electrophysiologic measurement of spasticity, but maybe just a little bit better than the H reflex. Because with one single pulse at the same location at where to deliver spinal stimulation, you can get reflex responses in most of the lower limb. So as you see here, you can deliver one single pulse. The electrical stimulus doesn't have to travel up through the peripheral nerve. It kind of at the dorsal nerve roots themselves. And in that multi-level activation, you can get responses in the quadriceps, you can get responses in the TA, the soleus, and the hamstrings all at one time. These reflexes also exhibit something called paired pulse depression, which was if you activate it once, a subsequent activation within a short period of time, that response will be diminished. So that's something called post-activation depression or paired pulse depression when you deliver two stimuli in pairs. So in somebody who is neurologically intact, in A, as you can see, the second pulse or the second triangle, that was where the second pulse will be delivered, you don't really see a response. So it's pretty dampened down. That depression is high. In somebody with a spinal cord injury, however, that depression is lowered because the excitability of the whole system is raised up. So you might expect that the second pulse, even though it's the same time from the first pulse, you would expect the depression because of the hyperexcitability of the spinal circuitry, you don't see as much depression. So we can use that as a measurement of excitability and how the change in that measurement might reflect some of the changes that are going on after TSS or spinal stimulation. So we can use PRM reflexes and biomechanics. The biomechanics, when I said this pendulum test, we use the first swing excursion or the amount that the leg can move before it catches. So you're moving into flexion before it reverses into extension. That'll be your first swing excursion. The same we can do for the ankle clonus drop test with the first drop excursion. We see how much the ankle moves before it reverses back into plantar flexion. And with PRM reflexes, we can identify a few things, a few characteristics. I just mentioned the paired pulse depression in which you have two subsequent pulses and the second one should be lower than the first. So the amount of depression we can measure. We can measure how much stimulation intensity is just required to get a response. So you would think that if it's really hyperexcitable, you need less to get the same response as somebody who is neurologically intact. And then we can look at the recruitment curve area. So over a series of intensities, increasing intensities, how much does that response increase as the intensity increases? So the amplitude of that response in response to how much stimulation we're giving. We embarked on a study that looked at transcutaneous spinal stimulation in 3 different conditions, and it compared the 3 different conditions. We had a continuous condition or tonic stimulation, where it's constant 50 hertz stimulation for the 30 minutes that the stimulation is on at one site, T11, T12. We also use burst stimulation. As we know, pattern stimulation is a little bit different in terms of the structures that it activates over time. Pattern stimulation has been delivered at the cortex. Pattern stimulation has been delivered at the spinal cord to identify a more neurophysiologically or neuroanatomically correct course of your day. You know, you don't go through the day with the same amount of stimulation at the same joint over the course of the day. That frequency might increase in those neurons, the frequency might decrease. So we tried to incorporate a pattern stimulation. Then we also did a dual site stimulation where we had an electrode at T11, T12, which is targeting more of the quadriceps, and then adding a lumbar electrode at L12 or L23, depending on that interelectrode distance that we required, to then target more of the triceps area or the soleus. Like I said, stimulation was delivered at 50 hertz in all of the conditions. There were 1 millisecond per phase stimulation, so it was biphasic symmetrical. We delivered stimulation below reflex threshold. So the amount of stimulation required to achieve a measurable response in the muscle, but below that, so that we tried to target the sensory afferents as much as we could, but without activating the muscle itself. For 30 minutes, the participants were supine, so they were laying flat, and the 3 conditions, continuous burst and dual site. At baseline, I'm going to kind of go through this pretty quickly. The characteristics were the same. There was no significant differences between the groups. The whole group was also reflective. Each individual condition was also reflective of the whole group. So we can say that at baseline, these groups were pretty similar into the pendulum test and the ankle clonus drop test. The baseline characteristics of the neurophysiology also showed the same thing. Reflex threshold was pretty similar across groups. The paired pulse depression was similar across groups. And the area under the recruitment curve was similar across groups, all at baseline. So I asked the question, do baseline characteristics of PRM reflexes and biomechanics, are they associated? And to my surprise, they weren't. I was hoping that they were. Maybe there was an explanation that we could give. Maybe there's something out there that can say, if you have this, you get this, but there wasn't any correlation. I have highlighted a few correlations that I think are important. This is a correlation matrix in which you're going to see that the two diagonal values are the same, but they don't represent anything different. The neurophysiology was associated with the neurophysiology, but the biomechanics at the knee was not associated with the biomechanics at the ankle. So somebody who has spasticity at the knee may not experience it at the ankle and vice versa, or they may experience both, and that could be affecting the neurophysiology. But interestingly, the amount of depression that someone experienced was correlated with their reflex threshold, or how much stimulation was necessary to even achieve a response. And it was associated with the area under the curve, which is the total output of the system across a given set of intensities. So now, what happened after spinal stimulation? I want to call out a few things. They're highlighted in red. The FSC, the change in the FSC had the largest effect size for the burst condition. For the continuous condition, the burst condition is the one that's patterned. It's kind of on and off, on and off. At the ankle, the first drop excursion was largest in terms of effect size for the continuous stimulation. We did not expect that with the added electrode for the soleus at the lower lumbars. At the lumbar electrode, we thought that the additive properties of the stimulation would target the soleus better, but we found that the continuous stimulation had the largest effect size at the ankle. There was no effect in terms of change in reflex threshold. So the amount of stimulation intensity or the amount of current required to get a response didn't change. There was a change in the paired pulse depression in terms of the depression actually decreased in the continuous condition, and the area under the curve changed the largest in the burst condition. So you can basically say that it was more excitable, the system was more excitable after burst stimulation. Using all of these variables, we wanted to ask the question, can we predict how much somebody is going to change from their baseline characteristics? So you come in, we measure something. Is that something going to help us predict what the outcome is going to be? And there are a few things that the answer is yes, it helped us a little bit. So at baseline, if somebody had a high FSE, which means that their leg could drop further, it means that they improved less. So somebody with high spasticity improved more than somebody with low spasticity. This is actually consistent with our previous work where we show that people with low spasticity may actually get worse from afferent stimulation. The whole body vibration, people got worse if they were in the low spasticity subgroup. And there was no change or a small worsening in the low spasticity subgroup when TSS was applied. The same holds true in terms of paired pulse depression and reflex threshold. If reflex threshold was high, the paired pulse depression was high, which is something that we didn't really expect. So we come back to this question of, can the electrophysiology help us fit the biomechanics? And that's the question that I wanted to answer as a whole of this whole study. And the answer is maybe. These might be two puzzle pieces that are linked somehow, but they may not be directly linked. And I think that's one important step to say, what we see in the clinic may not be measurable by bench measurements. And so the presentation, when a participant comes into us and says, I experience XYZ, they experience it, but it might not be measurable by the methods that we have currently. And so that maybe there's this in between that we need to elaborate upon and explore more to identify how these two things are related. And that's all I got for you.
Thank you, Evan.
Yes,
So
thank you.
stay up there.
Say again.
Stay up there.
Yeah.
Dimitri, Elizabeth. Now we get to talk. Thank you.
Those lights are so bright. Great job.
Anybody have sunglasses for Evan?
I know. I was so nervous. Hot mic. How's it going?
Yes, thank you. This table over here.
Hi, I'm Mika from New Health San Diego. Great presentation. My question is for Dimitri. In the footage of your subject who was standing in the combination of ESS and the NMES with the NEMS, he really looked significantly better with his standing posture. We've actually seen some similar outcomes in our center as well. My question is, do you see any residual effects after? Like, do your subjects feel better connection, sensory motor? And if the NEMS is off, is there a residual effect?
Can you hear me? Yeah, I should. So it depends. And usually I take with a grain of salt the subjective, like very subjective reports. Maybe I shouldn't. Maybe I should take it actually more seriously or in more consideration. But some people report that they feel differently after the stimulation sessions. Some report it's very different. It's very hard to have a like unified understanding like what's happening, right? Because someone said, I remember one of our first subjects said, I don't feel anything. I just like, before the stimulation, I feel like I'm floating in the air and people just there below and they're helping me. And during stimulation, I feel the same. I just see less people helping me, but I still feel like floating in the air. I don't feel much. Someone says something like, I feel more of the of power going through my feet, and I feel better my feet, right? So to me, it's very hard to put it as a report, and if I have a large sample size, for instance, right? So how would I can, of course, like create a table and say, didn't feel anything, feel like a force going through his feet. But as a researcher, I would like to have something more tangible, something more, like something that I really can deliver in a concise, like tangible manner. But answering your question, it depends, and it's very different.
We'll come back. Candace?
We have live stream questions. You ready for that?
Oh, go ahead.
Yeah, so we have two, and then I have a question.
Oh,
Put me
no,
in
you
the
don't
queue for
get
whenever.
two, and then we'll go over here, and then we'll get
Okay,
back.
yeah, that's fine. Just put me in the queue. Okay, so we have one live stream question for Elizabeth. And it's actually similar to a question I had myself. It's about the ejaculation index of orgasm in men. And it's basically this concept, is that metric validated the same way in both able-bodied persons as it is in persons with spinal cord injury? And I'll kind of tack my part onto that.
Yeah.
How do you kind of validate those metrics that you used in a spinal cord injury population?
Yeah, all the metrics we're using have only been validated in able-bodied people.
Okay, thanks.
Yeah, it sucks. It sucks. I'd like to validate them. I'd
Yeah.
actually just like to redesign a new survey.
Just my,
But,
yeah.
Can you elaborate that, like, on that? Is that, do you look at that as really problematic? Because
Yeah.
you're measuring this new reality against something that almost has no relation to, so able-bodied ejaculation almost has no relation to post-injury function, what that could even be.
Yeah. Well, and
Okay, all right.
yeah. I'd also challenge to like, maybe ejaculation is really only important if like you want that or you want to procreate. You can
Right.
have complete, so there's a lot of reframing, but if you really want to regain that, obviously people are researching ways to do it.
Okay, and then one
Okay.
more live stream question, and then we'll give the microphone up from this table.
And we'll go over here. next.
It's this drilling into this question, Dimitri, you raised about, this variable responses and recovery, and it's a two-part question from the live stream. And so one was, hold on, it's a long question. Give me a second. I'm paraphrasing in my trifocals here. One of is, did you notice a similar level of variability in autonomic recovery as well as motor recovery? It's part A. And then part B is about your kind of, you don't want to overhype, right? That kind of, that you described to us, your view. And the question is asking about if there's a vast majority of people that have had recovery of function from the stems, do you feel that people should still, do you feel like this is like, you're not overhyping as a way to not capture that? Or is there a way to kind of meet the middle ground between not overhyping, but also reflecting the larger experience?
Okay.
Yeah, paraphrase that.
No, it's great. Great questions, like several in one, right? Well, first of all, the variability in effects on autonomic function, yes, definitely. And I think it would be enlarged depending on the parameters of stimulation. Because as I said, like the more I work in this field, the more I understand that really the intensity of stimulation matters so much. And we see sometimes reports when people say, okay, well, the intensity of stimulation delivered in the trial varied from 10 to 150 milliamps, right? So how can we even compare these effects? Because they obviously had absolutely different motor thresholds. And with autonomic function, it's even harder to calibrate it or to put it in a frame, because again, for motor, I can at least have a relevance with the motor threshold, right? And see, okay, well, there was motor threshold or such percent of motor threshold, and we see certain motor gain. But for autonomic function, it's very hard to measure. So short answer probably, or long answer would be that yes, big variability. And then the second question, it's a very dear subject to me. I am a huge believer in weight bearing, positive effects on everything after spinal cord injury. And here is my space background kicks in, right? So weight bearing has huge positive effects on cardiovascular and neuromuscular and musculoskeletal systems. So and this is why actually I started doing the stimulation during standing in the first place. If we can facilitate somehow weight bearing and standing, and if we can promote this active standing other than just sandwiching someone in this easy stand, where it's just basically it's very passive posture. It's vertical, all right, but it's still it's less weight bearing, and it's no plugging in these reflexes through the spinal cord associated with more active standing. So if we have a means to facilitate somehow the standing, then by all means we have to push it.
And just so you caught Dimitri's passing reference, and you could also listen to our podcast. Dimitry used to work for the Russian Space Agency, whatever.
And for American too.
Sorry. Studying the effects of space on the human body, and that led, obviously overlaps to spinal cord injury, which is fascinating, which you can find on our podcast. Go ahead.
Hi, I'm Kimberly Gustafson from the University of Minnesota. My question plays right off of what we've been talking about, mostly for Dimitry. It has to do with the implanted E-stand and similar implanted epidural stimulators. It seems like we're in this space where, like you said, you're resigned to the fact that 50-50 shot that it's going to work, right? It may work to whatever degree. It seems almost like, not that we're okay with that, but we're kind of throwing our hands up in the air with, oh, we don't know why it's going to work for different people. I realize it's complex and why that's complex, but should we start actually figuring out what some of those variables could be? Because in my mind, right, figuring out why it's not working for some people is the first step in figuring out how to make it work for everybody, right? So I guess my question would be, should we be focusing more in trying to figure out why it's working for different people, and how do we go about doing that?
Well, I really appreciate this question. And it's $1 million question though, maybe $10 million. But absolutely, and almost intentionally, I didn't put anything related to the mechanisms, but in my presentation, didn't show you these squiggly lines and different waveforms. But it's actually my major subject, and I find myself more focusing on electrophysiological mechanisms in particular, to trying to understand these biomarkers of electrophysiological biomarkers of performance. And so far, I was not extremely successful in that. And this is as a researcher, I'm going absolutely crazy because I really want to provide a proof or at least categorize it somehow. But to me, the effects are so random and they perceived very differently among people, right? Because on the one hand, and this is also I'm referring to our conversations with Matthew, on the one hand, we see lots of from this stage, mostly we see lots of very positive reflections on the effects and how great it was to improve at least something after spinal cord injury. And I understand, I really sympathize to these reports, it's great. But on the other hand, I saw so many people with spinal cord injury who underwent this therapy. And maybe it's my fault because I'm trying to be neutral and I cannot just jump in around them and look, there's this muscle twitches. I think it's unethical as well. So I saw also 50-50 emotional response. And this hesitation from one group and enthusiasm from another group make me more phlegmatic on the, or hesitant to say, well, yeah, it's working. So let's just push it forward, because I understand for some people it may be heartbreaking that they would be hoping, raising their hopes so high that it would work, and then just crushing it, understanding then, okay, this is a minimal effect. So that's why as a researcher, I'm very on that side that, okay, well, until I really understand and comprehend those mechanisms, I wouldn't really aggressively push it forward. However, I also recognize, and I hear something, that if something is working, and also earlier today, we heard that if there is a tiny % chance that it will help, then yes, we definitely have to push it through.
Can I add with a question? I mean, you and I have talked a lot, obviously, but is there, the way you just described it, left out like maybe a middle space, which is you can push it forward and translate and yet still be working to understand the mechanism, understand how to optimize against the plug and play mentality, and also challenging the field to understand who are the responders and non-responders. And in addition, define, which is ill-defined at the moment, the clinical pathway forward in the real world, not in a lab setting, but in the real world. And so is there a way to do that in a parallel fashion so that what scientists are understanding in the study and in the dissemination feeds back to the understanding of what it's actually doing and who it's doing it for and who it's not? So it's not one or the other. Can it be all of it?
Absolutely, yes. But also I have to have a conversation with Gordon probably and learn how to breathe, because researchers already work under big pressure, and it's like lots of pressure, like tenure, publications, performance, all of this. But also if there will be pressure that, okay, well, no, you have to deliver. And by the way, you not only have to deliver, but you have to understand why it's working. That it's really hard for me to work under this pressure. And I was like, you know what? Just forget about it for a moment. Let me just figure it out and then I will deliver. But you're right. I must definitely do things in parallel. Evan wanted to say something.
I want to make a comment about that because at Shepherd Center right now, we're doing just that. And we have noted that there is so much research that's about to come out and coming out about spinal stimulation that patients are saying, well, why aren't we doing this? And so in order to adapt to that, we've rolled out a program where we are teaching our clinicians how to do spinal stimulation, cervical stimulation, lumbar stimulation, and work with their patients in an inpatient and outpatient setting to get more information back to us about what's working and what isn't. Because there are as many theories as we want to create about why certain things happen. And the mechanisms, there are only so many tools we have in our toolbox to measure them. I think that as technology moves forward And as more technology is available in order to understand those mechanisms in a living human rather than a preclinical model, we'll be able to get there. But I think it's really difficult, or a difficult scale to say what's more important, understanding the mechanism, or does it actually work for the person? And if it's working for them, continue to do it. If it's not working for them, what are the theories in which we can try to provide variation in the parameters that we're applying, try those and see if they work. And I think right now we're at just like the cusp of doing that in terms of the research and clinical worlds kind of colliding together to create this force for people with spinal cord injury to say, this is what we're gonna target, this is what we're gonna do. And I know that right now, like Dimitry said about biomarkers, NIH has this push for identifying biomarkers. It's like a call out to researchers. But I also think it's really, really important for translational research to occur at these organizational levels of, okay, we have a center that has access to hundreds of people with spinal cord injury. We have centers that have access to incredible research. And so how can we work together to do that? And I think one of the things is giving clinicians or making them feel empowered to do it. Because I'm going to say, as a physical therapist, when I was in PT school, I was told not to put electrical stimulation over the spine. I was told not to put it over the neck or anywhere near the structures of the neck. And so it's safe. And we're saying, you can do this. Of course, check your practice act, but it's safe to do it. And we're trying to say, okay, we want you to be involved in this and give us feedback just as much as people with lived experience give us feedback. And that's how we're trying to move this forward and say, okay, we need to understand the physiology. We need to understand the mechanism. But we also need to do what works. And the clinical presentation has to happen simultaneously.
Sure. I would add, I appreciate that. I love that. I would add one thing that's come out of some of our neuromodulation convening that we've done over the last few years is in the research setting, there's currently, and maybe it's improving, and certainly our efforts have been to raise the question, how scientists in their labs are profiling patients, what they are choosing as tools of measure, and then what they do with their data is critical to making that what you just described work. Because for many years, those things have been incoherent. People are profiling, they use different patients, different levels of injury, different severity, but they lump them all together. They're doing different tools of measure based on whatever we think is best in our lab. And then even the stimulation parameters and how they do it, how they do training, how they do rehab, all those things are all over the place. And getting some kind of consensus so that you can have coherence around that data, and then particularly share that data openly so it can be interrogated openly, and not just in a publication and a figure, but actually shared data that can be, again, back to something I said earlier today, pattern recognition, which sometimes we see what we want to see, or we don't see what we don't want to see. And so having everybody look at the data and identify things is critical to making that work, I think.
Well, my question's not as deep as any of that. So my question's for Elizabeth. First of all, kudos to you for asking really important questions that are really understudied in the field. And I'm thinking a lot about what you're actually studying in your trials and what you want to study. And when you're studying something like muscle physiology or reflex or walking or standing, there's not a huge psychogenic component. You're measuring the direct effect of stimulation. But for something like arousal in men and women, there's so much of a psychogenic component. And I wonder how much of an effect you have on these outcomes because you're measuring in like a research clinical setting. Is there how much of an effect do you think is being masked by the fact that people are freaked out to be aroused in this kind of research setting? And is there a way that you could maybe measure this like in a home environment for future studies?
Yeah, those are excellent questions. So it's interesting. I don't know if it suppresses, it might. I do think it might enhance because they're very nervous, right? Their blood pressure's high, their heart rate's high. They have like the white doctor syndrome. They're in the clinic room. They know they're about to like watch a video and, you know, I'm there and I'm, you know, it's awkward and uncomfortable. They're nervous, they're anxious. After they've done it a couple times, usually they warm up. But so sometimes we see that baseline actually being kind of high, which is why we include it. So we give them a chance to like, okay, you have the baseline, we'll see it's high. And then once it settles down, we're like, okay, they've calmed down. Now it's like more appropriate to like start the video. So it's almost like a washout, a pre-washout. So there's that. I would like to do it at home. That would be interesting because the way the laser, which is the device we're currently using to measure blood flow, it's a camera. So you have to have your legs spread and you're taking an image you can't close. There are other devices that have their varying pros and cons. It would definitely be possible to do it at home. You just have to lug all your equipment and like I have to be there. You can't do it yourself. But then, you know, with the home environment, you're still in bed. I don't know. I've thought about it. It's a good idea. Not in the cards right now.
Laura?
For Dimitry and Elizabeth, when you have a responder and a non-responder, how restricted are you in being able to either a little or a lot drastically alter the parameters for the non-responders?
Sure. We use a Bayesian optimization algorithm that a very smart biomedical engineering professor named Bottorff developed to choose the parameters for us. And so the computer's kind of making all the decisions. We've limited like the max and the min of both pulse width and frequency, but it's guessing around based on the responder, trying to improve it. So it's basically infinite possibilities, at least the way eSTAN works. Once you're in, we'll try anything.
For us, I'd say we are trying to get as aggressive as possible. But there are technical limitations and human mind limitations. For instance, if you imagine an array of 32 electrodes, each of which you can stimulate through, and then you can combine them, you have like those millions of configurations possibly to address certain questions or promote certain functions. And it's just, there is no way that we have enough time or resources to do this. I mean, and it's not, I'm not saying we as researchers, we don't have enough time. No, it's just, it's unfair even to our participants because we have 2-3 hour session and we can try 20 configurations out of, again, several millions. It's just like nothing, right? So, but again, there is this, I'm trying to communicate this sort of feeling, and it's sort of a pressure, you know, when we are doing, and in a way, it's not the rocket science, you know, like to stick an electrode and then try to stimulate and provide some electrical current and get some function, right? Again, it depends on the population, the amount of people you're working with. But then when we see publications that, oh, it's like, it's a nature level data, and you're like, wow, I kind of like, I saw this in my lab, and now I'm in this shadow of like, am I stupid? Am I doing something wrong? And then like, will now new participants, would they go to my center even, or they would go to the Nature paper center, right? And it's very disheartening, you know, like, and discouraging to kind of keep working on the same thing if you understand, okay, well, it is really, it's a small steps, but it's small steps for the community. But for instance, for my career, it may be quite detrimental steps, right? So because, okay, well, you don't perform, you don't show what other people show. So like, I mean, I didn't, it took me away from your question, but yeah, it's very aggressive search of new parameters to get those non-responders to respond.
But then it's really important to understand related to what I was saying earlier, that's an example. So what is reported in the media or what's reported in Nature, sometimes it's not very clear that, for instance, maybe somebody could move their legs already or could take, you know, rough steps and they've improved their walking. That's very different from someone who's complete motor has complete motor paralysis and is standing up and taking steps. That's about that question about patient profiling. So sometimes that gets lost in the filter between what's happening in the science and what you see in the media. That's really critically important because and we're very sensitive to that as an organization. That's why Sam does the headline patrol to unpack that stuff and say, oh, well, just remember, this person could move their legs or could stand or could step before the reported outcome, right? So those things are really important. Now I want to, we're done with questions. A couple of things. One is I would like you folks with SCI or family members of folks with SCI to talk to these folks today, tomorrow, about some of these questions, about how do we move forward? Do we do this? Even though we don't know how people are responding, we don't fully know the mechanism. Do we do this because we hear reports of people taking steps or standing up? And there are people in this room who have experience with stimulators who are doing some of that stuff, or having an orgasm, or no longer using catheters, or sweating, or there's a whole bunch of things that people are reporting and you've heard about. So I would love you to engage in that point of view conversation about what do you think? Like what do you with SCI, like what would you risk knowing that you don't know if you're a responder or not? And because I think that's an important part of the conversation that would add to what you said, Evan, which is another critical piece is how are the people with spinal cord injury communicating in your program that you're developing for stimulation? What are you hearing from people with SCI? What input do they have into that project? Because that's really critical. And that's, again, why we're here. As you come back together, and as I mentioned, we just had that discussion around the future of spinal cord stimulation and real questions about understanding what works, how it works, mechanism, how do we understand profiling for people to know who are responders and non-responders. Now we are going to hear from Dr. James Guest, who's going to talk to us about the recent Uplift pivotal trial using transcutaneous stimulation to affect upper extremity function, sponsored by the company ONWARD, that I suspect you are familiar with. So please welcome Dr. Guest. Hello, Jim, happy to have you with us. Wish you could be here in person, but understand down in Miami, it wasn't so pleasant yesterday. Thank you, welcome.
Thank you very much. Just checking that you can hear me okay?
Yes, we can.
And also that I'm in the right presenter mode.
Yes, no. We don't see the full screen. There we go.
Better?
Perfect.
All right.
How about
great.
it?
Thank you. So I am sorry that I'm not there today. Flights out of Miami yesterday were canceled, and so I wasn't able to make the trip. And Matthew already gave the title, which is a report really about the Uplift clinical trial. This was reported earlier this year by way of a publication. So I work at the Miami Project to Cure Paralysis. For the purpose of this talk, I'm a paid consultant of ONWARD Medical, but in most of the other things that I do with ONWARD, I am not a paid consultant. So we're going to talk about what's called ARC-EX therapy. So this is the name that has been given to the transcutaneous stimulation device and system and application that ONWARD has put together. And we've already heard a little bit today about transcutaneous stimulation and some of the excitement about the changes that occur in some individuals. So this system consists of cathode electrodes that are applied over the target for spinal neuromodulation at the back of the spine, cervical spine in this case, and then the return electrodes over the hip bones. Then there's the stimulator unit, which is battery powered. And then there's the ARC EX app, which is on a tablet. And so what you can do is work out with the individual who's receiving stimulation and the therapist, what is the program that that individual wants to use, and then optimize it for that particular individual, and then store that program. And that'll come up later when we talk about the home use study. So Dimitry was talking about Nature papers, but this paper was published in Nature Medicine earlier this year. And I'm not the PI. The PIs of the study were Chet Moritz and Adele Field-Fote. I was a site investigator for the University of Miami. So yes, there were 14 sites, very nice mix from the east to the west of the United States, also including Toronto, and also the Netherlands. Investigators were included in this study, and there were 65 initial participants. So this is a methodology to use neuromodulation to engender neuroplasticity. And so it consists of functional task practice. In the study, for the first 2 months, there was no neuromodulation delivered. And then in the second 2 months of the study, the functional task practice was combined with the ARC-EX therapy, and there were 3 sessions per week, an hour per session. Now, what's important about the functional task practice is that when you do this, when you try to do a task, you activate a subset of neurons in your nervous system, and they're much more activated, of course, than other neurons. And so this is the opportunity for occur. And then we believed in this case that the neuromodulation facilitated the neuroplasticity. So there was a screening in order to determine if you were eligible for the study. Then there was a baseline assessment of a battery of tests we'll talk about. And then there were 4 additional assessments. And the first 2 months, as I mentioned, was functional task practice only. And then the last 2 months were functional task practice plus neuromodulation. So the study goal, as most clinical trials are, it was to test for a statistically significant improvement in the strength and function of the hands and arms in people with tetraplegia. And so the stimulation in this case was delivered with a carrier frequency. This was a 10 kilohertz carrier frequency, which is believed to have a number of effects, but one of those effects is to make it possible to deliver more energy more comfortably. So people talk about different mechanisms that include a reduction in impedance and other possible effects of this frequency. So the stimulation parameters, for the most part, people used a biphasic waveform. So this is a burst mode of stimulation, which most of the time people were using 30 hertz. And then some people responded better to monophasic waveforms. Then Dimitry also mentioned about the range of parameters. In this study, we wanted to optimize the individual's response to the therapy. And so the therapist was allowed to use the parameters that seemed to facilitate the task to the greatest extent. And so typically this was between 20 and 40 milliamps. So aiming to facilitate movement, not to cause it. That is that we're not trying to stimulate the motor neurons directly, but to facilitate their activity. And then the site of the electrodes was optimized with the idea of having one electrode above the injury and one below. Now, per these criteria that were set forth and agreed upon by the FDA, the effectiveness was determined to be present in 72% of the individuals who were within the study. And as I'll show, this meant that they exceeded the minimally important difference criteria for one strength and one function metric. And of course, the other part of the study was to determine if there were any serious adverse events associated with receiving the stimulation. So this is the battery of tests that was utilized, and there's a lot of interesting information here. And I also would encourage you to read the publication. There's two publications. One publication reports the trial. The other publication is about the stimulation parameters that can be used. So if you look across the top left, here we can see for the upper extremity motor score, very commonly utilized outcome metric in spinal cord injury, that during the 2-month functional task practice period, there wasn't much change. Then when the stimulation was brought in, there was a real change in the slope of the recovery curve. And then you can also see across many of these metrics that had the study gone longer, there might have been a greater extent of recovery because the slope was still quite strong. Now, another thing that was really interesting is that there were changes in sensory scores, and I don't think this was really anticipated, but in fact, there were a number of points gained in the INSCI sensory score, upper extremity sensory score. And again, you can see this trend that during the so-called run-in phase, there wasn't much change. And then when the neuromodulation was introduced, we saw a sharp uptick in the slope. Some of the other very important outcome measures that were used were the QT, grasp prehension, and grasp. Is that from the beginning of the study to the end point at 4 months, there was an observation of recovery. And again, this idea that had it been possible to go longer, there might have been more recovery. So we mentioned that 72% of people were a responder according to the definition that was given, but 90% of people improved in at least one of the primary strength or function assessments. So most people who participated had some benefit. And also a large proportion of individuals reported an improvement in their quality of life. And there were participants who had been injured for a long time, up to 34 years before engaging in the therapy. There were other things people talked about. They talked about reduction in spasm frequency, improved sleep, improved upper body sensation, including the sense of touch. And examples of what people learned to do or were able to do included lifting cups, pushing a button on a remote control, picking up objects with a fork. And one of our subjects in Miami recovered the ability to transfer himself from his bed to a wheelchair, which was a very important change for him. Now, we recognize that there's a lot of barriers that can potentially limit continued in-clinic therapy. It's not easy for people with tetraplegia to come into a center 3 times a week to engage in the 1 hour of therapy. There's a lot of significant out-of-pocket expenses that can occur. Transportation can be a challenge. And then if we think ahead to whether this will be approved and enter into use in clinic, there will likely be reimbursement caps for its in. So there was a second study. This was called the LIFT Home Study, and it evaluated safety, feasibility, and effectiveness in the home setting. And so there were 17 participants in this part of the study. And these participants were drawn from the earlier Uplift in Clinic study, and they had to be within 1 year of having completed the in-clinic part of the study. They varied markedly in the length of time between the end of Uplift and the onset of the in-home study by approximately 104 days. And the number of sessions that were achieved with the home study was between 12 and 20, 60 minutes per session. And the subjects who were enrolled in the home study, not all of them were technically responders, as I previously discussed, but 5 of them were so-called non-responders. And it was required to begin the home study that the caregiver would be available to help with setting up with the electrodes and monitoring the study. So the assessments were repeated at the baseline for the home study and then 1 month afterwards. And so sessions per month in the in-clinic phase were 13, at home 12.3, so no meaningful difference. Session duration was similar between the 2 studies, and the total monthly treatment duration was around 750 minutes. So I mentioned before that there are programs that can be set into the tablet. These are generally worked out with the therapist and the subject. And then as that becomes stabilized, people choose to use those programs. So very little variation occurred from the programs that were set in the clinic during the home study. There was only 1 person who had an unscheduled visit to change their parameter waveforms. So home use offers easier access to the therapy, allowing people to train more. 96% of the attempted home therapy sessions were completed. 66% were completed without any device issues. The commonest problem was that there was a reading of high impedance. This is a protective mechanism built into the therapy. And so when that occurs, it's obvious on the pad. And generally, that can be remediated quite quickly by repositioning the electrode and making sure that it has very good contact with the skin. And 4 participants actually completed more sessions in the home study than they had in the in-clinic study. So there are logistical advantages to this. So the home therapy was effective, even though it was relatively brief in showing recovery for QT and pinch force. It was a small study, and so it wasn't really powered the same way that the in-clinic study was powered. And so this is an example of some of the recovery trajectories for different measures. And so I'll draw your attention to QT. So we had the run-in, we had the in-clinic phase, and then there was a small decrement in the QT score during the interval when people were not receiving the neuromodulation, and then there was a recovery during that month. And you can see that this reduction in recovery was apparent across different outcome measures. It didn't go anywhere close to the original baseline, but it's very encouraging that recovery could be achieved again after this interval without stimulation. It also means that there may be a need for some type of ongoing stimulation at some frequency to maintain the benefits that are determined. So the other improvements were reported in quality of life, pain reduction, and independence. So there were significant changes in the pain interference with day-to-day activities. Benefit was reported in psychological health, and there was a small increment of improvement in the SCIM-3 self-care subscore. So continued therapy at home as well as in clinic is feasible, safe, and effective at maintaining and extending in-clinic gains. There were no serious adverse effects that occurred either within the in-clinic or the home study. And the gains that were important for arm and hand function were maintained during the LIFT home study. So basically, both of these studies are very encouraging. The in-clinic study showed that the therapy with the neuromodulation was superior to the functional test practice alone. And then the home study showed that in the selected participants who participated, it was viable to deliver the therapy at home. So that's the end of this presentation. Thank you very much.
Thank you, Jim. I think we are, if he's here, we're going to go ahead to Dave. And Dave's going to give a presentation, and then we'll bring you back for panel discussion. Sound good?
Sounds good.
Okay. Now, everyone, please welcome the CEO of ONWARD, Dave Marver. And again, you're all familiar with ONWARD, right? A company based in Europe, working to bring spinal cord stimulation devices to market. And Dave is the engine behind that, or one of the engines behind that. So please welcome Dave Marver.
Well, thank you, Matthew. Can you hear me okay?
Yes.
And you can see my screen, the slides?
Yes, we can. Perfectly.
Super, super. I'm sure a number of you have questions for Dr. Guest following his outstanding presentation. Please make note of those, because when I complete my prepared remarks, there will be an opportunity to ask Dr. Guest whatever you have in mind. I'm coming to you from a darkened hotel room in London. I connected with Dr. Guest yesterday, and we made what I think is the prudent decision to do this via Zoom. But like him, I do regret that we're both not there with you in person. So thank you for your understanding. The title of this session or segment, I think, Matthew, is 5 years finally here? And indeed, we do believe, and it's our expectation at ONWARD, that we are ready to unlock functional recovery after SCI, and that we could be a mere weeks or months away from our first FDA clearance and from the opportunity to indeed make the compelling therapy that Dr. Guest just outlined available to all of you, at least in the United States. Let me just tell you who we are at ONWARD. We have now 110 people working around the world. As Matthew said, we have significant operations in the Netherlands and Switzerland, but we have a growing team as well in the US. And that team is conducting clinical trials, but we've also started to hire a field organization to provide training and support for the expected introduction of the ARC-EX device later this year. Our vision collectively is that, empowered by independence, people with spinal cord injury will enjoy life in the ways that matter to them. That last part is quite important to me and to us. I've attended many of these conferences where there's been frustration voiced, particularly by those who are injured and are members of the community. Why is everyone talking about mobility? And yes, we are also focused in part on mobility, but it is critically important that we also introduce therapies to address things that can impact activities of daily life, hand and arm function, bladder and bowel control, blood pressure dysregulation, sexual function. All of these things are in our pipeline, and we're committed to doing everything we can to bring them forward. This is our technology. We have 3 technology platforms, all of which stimulate the spinal cord to restore movement and other functions. At left is our external or transcutaneous stimulator, what we call ARC-EX, that Dr. Guest just detailed. In the middle here is our fully implanted platform, which something we call ARC-IM for implantable. And then at right, you can see we've started to combine the implantable platform, ARC-IM, with an implanted brain-computer interface to enable thought-driven movement. So that's further away, obviously, but it is compelling and interesting, and it's something we'd like to continue to move forward. Here are the timelines, probably what's most important to all of you. So in the near term, our almost singular focus is on getting ARC-EX cleared by the regulators and in the clinic. We also want to start the clinical trial, the global pivotal trial called Empower BP, for blood pressure dysregulation with the ARC-IM platform. And we hope to have that on the market by 2026, likely 2027 in the US. And thereafter, we have a very good opportunity to expand the labeling to encompass additional recovery targets and also additional platforms such as that which is augmented by a brain-computer interface. You saw this system overview in the previous presentation from Dr. Guest, so I won't spend any time on this. So the first indication for ARC-EX, the first recovery target, is indeed strength and function of the hands and arms. Why? Because this is the #1 priority among those of you with tetraplegia. So that's our first recovery target. And for those of you who haven't seen this in action, this is a video from Dr. Chet Moritz's lab at University of Washington. And you can see someone injured 12 years ago is back in the clinic, and he's being asked to undertake a rehabilitation exercise as shown. Now, stimulation with ARC therapy is applied, and you see what occurs. So indeed, he's able to perform the movement with the benefit of stimulation. Now, let me be clear. This is not a neuroprosthetic. It's not a wearable. This device and this therapy is intended to be used for up to an hour a day in the clinic or in the home. And as you could see, when the therapy is on, it enables a person to move in a way that they otherwise could not. And by training performing that movement, some function is regained. And you saw those data in Dr. Guest's presentation. 72% responder rate, meaning they improved both strength and function. 90% of participants in the Uplift study recovered both strength or function. So I should say that again, 90% recovered strength or function. 87% reported improvements in quality of life. And notably, the improvements were observed up to 34 years after an injury. So we're really excited and keen to get this out there. Now, I'm sure those of you in the community are, you don't necessarily want to undertake this therapy to move ping pong balls around. You want this to impact activities of daily life. And Dr. Guest noted that one of his participants was able to effect transitions with the benefit of the therapy. Others in the study were able to lift filled cups or pick up forks that had food on them, and so on. And this is meaningful. This is a quote from one of the participants in the pilot study at University of Washington. And what did she say here? She said, being able to open a Ziploc bag does not give you the ability to go out and start dating or start making new friends. That Ziploc bag does not do that for you. However, it's the beginning, and it's the beginning of being able to find a little bit more self-worth. Forgive me for these alerts that are coming up. I hope that you could see that properly. Okay, so the big question, when will ARC-EX be available? So we submitted the de novo dossier, the de novo application to the FDA around April 1st. Normally, the de novo application review timeline is 8 to 9 months, and that would put clearance near the end of the year, sort of November or December. And that's our hope and expectation, and that's what we're planning for. I should mention a de novo application is a type of application for a non-significant risk device like this, for which there is no predicate. There's never been a device like this that's been cleared and commercialized. Those of you who are like me, tuning in from Europe, we expect EU availability and in jurisdictions that are governed by CE mark, probably in the second half of next year. We're working on FDA first. Okay, so what's the rollout plan? We're first targeting making this device or system available in rehabilitation clinics. And we plan to offer those clinics robust training and support, those of you who are clinicians in the audience. That includes professional education, including hands-on training, a digital starter kit, which includes videos and other online resources, and community resources, connecting those of you who are clinicians so you can share best practices on clinical workflow and application of the therapy. Then, as Dr. Guest referred to, we plan to support transition to the home for flexibility and convenience. It's not easy for people with tetraplegia to come to the clinic for this care. And here again, we plan to offer robust training and support. For example, convening SEI community days to support education and peer engagement. Home use training, we expect, will be delivered by your trusted clinicians in the clinic, but with support from our field team. We also plan to provide remote assistance via telephone or video conference, and importantly, insurance support for prior authorizations and appeals. So that's the ARC-EX device. We also have a significant pipeline of recovery targets with our other platforms. The first of them for our ARC-IM device, which I'm holding up here so you can get an appreciation for the size. So this is a fully implanted system. The first indication we're pursuing here is improved blood pressure regulation. This is the system overview for the ARC-IM device. So we have our own purpose-designed neurostimulator, so purpose-designed for delivery of therapies that will benefit people with SCI, we expect. We have our own family of leads that are placed on the spinal cord in the area of the spinal cord responsible for controlling a given movement or function. This whole system is recharged and receives programming instructions wirelessly through the skin using this hub. The clinician uses a tablet programmer to define the stimulation parameters. And those of you who are injured and have this implant can control the device, can turn it on and off, and control the delivery of therapy with a smart watch. That's a novel part of our system. Now, we're starting with blood pressure. Some of you are familiar with this as an indication and an important recovery target. This is principally something called orthostatic hypotension. So low blood pressure that's tied to changes in body position that occurs when you sit upright or stand or even after meals. And this is well acknowledged by a fairly significant subsection of clinicians. But for others, I think that they've just grown used to the fact that people with paralysis just feel bad sometimes, that it's just acceptable, when indeed it potentially can be improved and addressed with the benefit of this therapy to bring the blood pressure to a more normal range. And I think there's no better way to illustrate that than from hearing from one of our study participants. This is a young lady from Belgium who was injured while vacationing in Serbia. And I'll let you listen to her tell her story. It's very powerful.
I was very homebound. I didn't leave my home very much. Couldn't do anything, basically. Was in bed most of the time, or in the couch, or in my chair, but then with my legs up, because otherwise I would just faint. Maybe 10 times a day, maybe 12 times a day. It was no life, to be honest. And when the researchers turned the stimulation on for the first time, I was still in the ICU. And I remember to feel the energy rushing through my body for the first time in 9 months at the time. It was an amazing feeling. And I saw my blood pressure value on the screen next to me rising to a normal level. It was like a sort of rebirth to me. And that meant the start of my real recovery journey. Of course, I needed some time to adapt to the system and to, learn how to work with it. But I immediately saw the opportunities coming back. I could immerse myself into rehabilitation, build muscle mass, have a social life again, go out with friends and family. And it also allowed my brain to function again. Since November, I've restarted my PhD at FWO, which is just amazing. It was impossible before the surgery.
So really compelling story and just such an impressive young woman there. This is important. And I think there's some education that needs to be done among some clinicians who don't attach importance to this. No one should feel the way this young woman felt. And so those of you who are interested in potentially participating in our global pivotal trial for this therapy. It's called Empower BP. We expect it will start very early next year with the majority of the sites in the US, plus Canada, plus the UK and Europe. You can register on our website, and please indicate your interest in potentially participating in this study, and we'll put you in touch with the clinical sites who can make the appropriate determination as to your eligibility and suitability. Okay, the company was actually founded to help people stand and walk again. Of course, we're focusing on some other things right now, as you can see, but it is notable that we've made progress here. And I think the best way to illustrate this is probably to show you the news story from BBC that covers 2 of the 9 study participants from the STIMO trial that was published in Nature actually several times over the past few years.
Michel Riccardi was paralyzed after a motorbike accident 5 years ago. His spinal cord was completely severed and he has no feeling in his legs. But he can now walk while using a frame because of an electrical implant that's been surgically inserted on his spine. Using a remote control, he sends signals to his leg muscles, which enables him to walk. It's the first time that someone this injured has been able to do this. Michel, I can't believe that you were paralyzed once.
I know it's very close to before the accident, yes. I stand up, I walk where I want, alone. I can do the stairs. I just got stimulated.
David MZ is another patient helping scientists with their research.
It looks like it works.
Which has been published in Nature Medicine. They don't use the technology to help them walk in their everyday lives. Instead, they use it to practice walking, which exercises their muscles.
This is not the cure for spinal cord injury, but it is a critical step to improve people's quality of life. We are going to empower them with the ability to stand, maybe to make some step. It is not enough. It's not a cure, but it is a significant improvement, I believe, for the future.
David and Michel strolled together on the banks of Lake Geneva. So far, 9 people have been successfully treated with the implant. David was one of the first people to have the implant. Michel is the latest. Both of them say that it's transformed their lives, and the hope is that the treatment could benefit many more people.
Ready, set, go.
At his home in Zurich, David races with his 1-year-old daughter, Zoe. When David had his accident 12 years ago, he was just 22.
You're too fast, Zoe, wait for me.
He was paralyzed, unable to walk and unable to have a child. Regular walking with the implant has improved his health to such an extent that he was able to father a child last year.
It was great fun. It's the first time I've been walking with her in that way. She with a baby walker, I with my walker.
She can beat you.
She can. And she even beats me without the walker, so it's a bit embarrassing.
Yeah, so I like that video, actually. It doesn't overhype things. This is a therapy that has a ways to go. You can see it's being used as a training tool today. It can potentially help people be more healthy, recover muscle mass and so forth. But a lot of rehabilitation is still required, and we are in the process of streamlining things so that the programming can be done more easily and has some automation involved. So we're continuing to work on this. This is potentially the indication that we'll bring forward after blood pressure with the implantable. There's some other things that are also interesting. So stay tuned on that. I just wanted those of you who have interest in this to know that this remains in a way our North Star, but we want to make sure that we attend to all of these important activities of daily life in the meantime. And then in the news, of course, quite a bit lately, I think because Elon Musk is involved, is the work we're doing with brain-computer interfaces. So this is not Neuralink. We're not trying to implant something in the brain to connect to a computer to combat the rise of AI. Our purpose is very much, as you can imagine, aligned with our mission. We want to use brain recordings to help people move better and recover more natural movements. And we're currently doing implants. We've done 3 so far, 2 for mobility and 1 for hand and arm function. This is the way the system works here. So there is a brain-computer interface, a recording device that sits on top of the motor cortex. So it's epidural, relatively non-invasive relative to other BCIs. The BCI records a person's intention to move. It sends those signals to our system, which decodes them and then translates them into specific instructions for our implantable neurostimulator, which then stimulates the spinal cord to create thought-driven movement as shown. It's a true digital bridge. This is just a brief video of the gentleman who was featured in Nature and got a lot of news coverage earlier this year, who was previously a STIMO trial participant. So he had a spinal cord stimulation device. The BCI was added, and he was able to walk more smoothly, control his stride length, traverse more challenging terrain, and so on. So at this point, we're in learning mode. We've done 3 people. We have funding from the Christopher Reeve Foundation and the European Innovation Council to do 8 more. And we'll continue learning from these study participants, and that will help us inform whether we invest in a pivotal trial to bring a BCI augmented system to the market. This is just to temper expectations, likely not going to reach the US market before 2032, maybe beyond that. In the meantime, as you've heard, we've got many planned therapies that we expect will reach the US market, but this is important for us to explore because it could make our movement-related indications that much better. I also wanted to just add this slide because this is a translation-focused segment, and most of you may not know about this. So there is, for the first time ever, a true venture capital fund that is solely dedicated to supporting innovation in SCI. The fund just came together, was just announced this summer. It has $30 million to start. And the founding partners or contributors to this are global advocates and provider organizations, such as the Reeve Foundation, Spinal Research out of the UK, Wings for Life out of Austria, the Promobilia Foundation out of Scandinavia, and then right there in Atlanta, the Shepherd Clinic. And this is going to provide, in addition to capital, they're going to try to connect these fledgling enterprises and entrepreneurs with scientific expertise, an operational network, and advocacy. So really good news. And this is an evergreen fund, which means nobody's trying to make a profit on these companies. Let's hope there are profits that come out of this because it means that these fledgling companies are growing and succeeding in bringing therapies forward. But by evergreen fund, it means that any profits that are gleaned, that are harvested, will go right back into the fund to invest in additional and future companies. So if you have interest in this, they have a website called SCI Ventures, and it's really a huge breakthrough in terms of translation. It's something that's been long needed, and I just wanted to make sure that the group here at Unite to Fight in the audience was aware of this important development. So Matthew, that's it for my remarks. If you'd be happy to do what you do quite well and be the master of ceremonies and direct questions to Jim and I, we would really appreciate it.
Thank you, Dave. I'm sure our folks will have lots of questions. Jim, are you there as well?
I am, yes.
Okay.
There are some questions in the chat, Matthew, if you want to take on any.
We will get to those all.
Okay.
Anyone? We'll start right here. Miranda?
I have 2 questions for Dave. First, I'm assuming that Q4 projection for the external devices for clinical use. You said the focus after would be for home use, but do you have a time frame projection? And then do you happen to know price point wise what it would be?
Yeah, thank you for your question. So the application is, as I said, in front of the FDA, and I don't want to put pressure on FDA. They have a job to do, as you know. And also we have to be relatively non-specific because we're a publicly traded company. And so what we've been saying is that we expect approval in the 4th quarter. We've also, though, said that we expect that the approval is likely going to be agnostic in terms of venue. So we're hopeful the approval will allow us to market and make the device available either in the clinic or the home late fourth quarter. Having said that, it's likely that we're going to choose to first make it available in the clinic. And this way, clinicians can grow comfortable with the therapy and the programming parameters, as well as those injured. You can come into the clinic and gain some experience with it, and your caregivers can gain experience with the programming parameters and the placement of the electrodes. So I don't envision a situation where we have to wait 9 months or a year before the device is available in the home setting. Folks like Jim and clinicians around the country may decide that they want to start sending people home with the device within a month or two of it's available in the clinic. We want to leave that decision largely with them. It's the clinician's purview to determine where and how the care is delivered. As far as price point, again, I want to be relatively silent to that just because of where we are in the process. But I will say that it shouldn't be an issue for clinics to purchase the device. We've had discussions with clinics in the US and Europe. We've identified an expected price point that they think is fair based on the feedback that we've received. And in the US for home use, there's actually a large group of people whom we think can benefit even without a reimbursement code. And that includes people who are cared for within the VA system and those who are covered by workers' compensation. Others, for a while, we're going to have to help you fight on a case-by-case basis if you are insured by Aetna or United Healthcare or one of those groups.
Thank you. And the second question, sorry, just for full transparency, in the external device, the 2 videos for Michelle and David, I believe, do you happen to know their ASIA level and their level of injury offhand?
Yeah, so that was for the ARC-IM device, and that was 2 of the study participants in STIMO. I think I know for a fact that Michelle was ASIA A complete. So he was one of the 3 participants who were enrolled in the study who had complete injury. I think that David might have been a sort of a B and maybe barely a C because of anal function or something. So Jim, do you happen to recall? You're pretty good at knowing the literature, but
which patient, which subject are we?
This was David, the one who was walking alongside his daughter in the video. So it wasn't from your study, but in any case, I think the important thing potentially is that Michelle was ASIA A. So even with those with severe injury, there is some potential to recover the ability to stand and take some steps. I will say, though, he's a very athletic person and he really does train hard. And I think that that's not necessarily the norm.
That's great. Thank you.
I just want to Dave, add on to what Miranda asked of as it pertains to the ARC-X. Will this be available in the clinic for anyone with an SCI, or is it limited to level of injury or severity of injury?
So we don't have the approval yet, but I think the study enrollment criteria are instructive in that we enrolled just ASIA B through D here. We did not enroll completes.
ASIA B through D?
Correct.
Okay. So if you had ASIA A, you would pursue it off-label if you wanted to try to use it?
Yeah, again, we certainly can't promote it off-label. Once it's in the clinic, clinicians do what they do.
Of course.
That's not something we will promote or encourage.
Okay, thank you. Louise?
Yeah, thank you, Matthew. Dave and Jim, thank you both. This is just so exciting. I have a son who is ASIA A complete. My question for you, for both of you, and perhaps mainly for you, Dave, is the brain-driven movement implants that are expected in 2032 or maybe beyond. I heard that piece here in the US. Could you give us a little bit of insight about what's happening in Europe, since that looks like that's our process that's taking a while through the FDA? Are they, are you already using them in different countries in Europe? And can you tell us what that looks like?
Yeah, indeed. So the implant itself, the brain-computer interface, does come out of France. So it is a European technology. For us, it's quite well suited because it is epidural. It also has 7-year human safety data, which is quite unique within the BCI realm. There's a lot of hype in the US around BCI, but many of these technologies are just beginning to be used in humans, often just acutely during a surgical procedure, and they're not persistently implanted. So to have a device with 7-year human data that, again, doesn't penetrate the dura or the brain makes it really well suited for what we're trying to do. And it also provides sufficient resolution to drive movement-related indications. So, okay, now I'm going to actually answer your question. So what happens with medical device regulation is there's a bit of a pendulum. And sometimes it makes sense to commercialize things in Europe first. Sometimes it makes sense to commercialize things in the US first. And this is mainly linked to the attitude, the relative conservatism of the regulators on either side of the Atlantic. We happen to be in a decade where it's easier to get things approved in the US, which is why you hear us discussing the fact that ARC-EX we expect will be available in the US far in advance of when it will be available in Europe. And unless things change significantly, and there may be a new FDA commissioner, et cetera, I would expect that will be the case for the ARC-IM and ARC-BCI. But again, things can change, and we want to go wherever we can help people the soonest. So we'll adapt accordingly.
Okay.
Thanks.
Yeah.
From the group chat?
Yeah, so we have a question from the chat. So this is from Jesse McNeil. For those that already have an epidural stimulator, would a one-time surgery be possible to remove the existing stimulator for the ONWARD epidural stim?
Well, so I'm going to let Dr. Guest take this because he's going to know a lot more about lead removal. I think much depends on where the lead is and what you're trying to achieve, but maybe Jim, you can take it.
Yeah, I think the question, first of all, is whether we're talking about a clinical trial or whether we're talking about the application after clinical trials have been completed. And so it'll be really important in the clinical trials to have appropriate entry criteria. I think that the specific question as to changing out a stimulator for the ONWARD technology, that'll have to be addressed when it's clear as to what exactly the study is that we're talking about. It may come up. There's some interest in where is optimal for stimulation in terms of the hemodynamic response. So as Dave mentioned, it looks like the lower thoracic spinal cord may be more optimal for the placement of stimulators. And so if there was a stimulator in a different position, one might be willing to switch that out. But it's going to be very important during the clinical trial phase of this that we really have the subjects as similar as possible. And so there could be things like some scarring. That's where oftentimes an epidural lead becomes encased. And so that can actually alter the function of the stimulator by way of impedance and resistance and things like that. So it's not easy to answer that question at this point.
And I think it is a thoughtful question and an important consideration. So those of you who might be considering getting a pain stimulator, for example, implanted today, that might in fact contraindicate you from getting a sort of a purpose-designed, approved stimulator implanted as early as 2027. So it's obviously an individual decision, but that it is a consideration for you.
One more from the chat, and then we'll go to Cynthia.
These two are related, somewhat related, Jim, to what you just described. So there's a question about like how much movement in the level of the spinal cord is needed to achieve different functional targets. And so again, the blood pressure was one. People were wondering about bowel and bladder. Has that been considered? And then the kind of second part to that question is people wanted more clarity from the chat about clinical trial enrollment processes and entry criteria. So they wanted to know more about where they find out information regarding that.
Yeah, I think Dave may want to mention this, but my understanding about what ONWARD is doing is they're developing a suite of leads that are optimized for the different locations in the spinal cord. So for example, the spinal canal is different for thoracic spinal cord placement than it is, for example, over the lumbosacral spinal cord, where you might want to stimulate for something like improvement of bladder function. So I think, again, that the technology is being developed to be optimized for each application. In terms of the entry criteria, the study, which is called the Empower study, when it is open, then those enrollment criteria will be posted on clinicaltrials.gov. I can tell you that we're looking for individuals who have severe hemodynamic instability, particularly with disabling orthostatic hypotension. Those will be the individuals that will be first selected for that clinical trial.
Yeah, thank you, Dr. Guest. That's excellent. If I may, just one more thing, Matthew. So yeah, our philosophy here is, those of you who've been in the field for a while, you know that if you stimulate the spinal cord, you're likely to get some serendipitous result or improvement. But that's not good enough, I think, if you're, for most people who make the decision to undergo an implant procedure. So it's our belief that we want to be able to offer therapies with precision, where you can say, okay, if you stimulate in this area of the spinal cord in this fashion, you are highly likely to get the desired result. And therefore, it's worth the risk of undergoing an implant procedure. So this is philosophically how we're approaching things. As far as the clinical trials, as Jim said, the overall study will be posted on clinicaltrials.gov. But in the meantime, please go on our website. We have a form you can complete. Please indicate very specifically that you're interested in participating in this blood pressure study called Empower BP. We will then take those inquiries and direct them to the 15 or 20 clinical study sites, most likely in your area, so that you can participate most easily. But again, the decision around enrollment and suitability will be made by the investigator, not by the company.
So in response to that, Dave, which may be more a question for Jim, and I'll display my ignorance or naivete, maybe. If I understand the implications of what you just said, given the current device size, technology, the person with spinal cord injury would sort of have to decide which function they want to chase. Placing lower down toward the CPG is lower extremity movement, even lower potentially sexual function, up higher blood pressure, etc. So is there a future plan for a larger paddle to cover more of the cord, or is it in fact a question of optimization, not placement, or is it a question of optimization and placement to gain that variety of function?
Well, you can go ahead first, Jim.
Yeah, so I think that what we need to do is we really need to figure out one thing at a time. And we really need to get really high quality definitive evidence for sort of each application. In the future, I don't see any reason why we couldn't have several leads in the spine that could, be optimized for different functions. That would probably work better than sort of a whole spinal sleeve that one might think about. But I think that the efficacy really needs to be rigorously established. And of course, we haven't talked at all about the cervical spinal cord, which is also ripe for the application of stimulators for recovery of the upper extremity.
I agree completely. Yeah, it's likely that we will either have multiple leads and potentially multiple neurostimulators, or future generations of neurostimulators will have more channels and might facilitate control of multiple leads. We'll have to see. But as Dr. Guest said, let's do it right. And let's figure out which of these work and work well in a predictable and scalable fashion so that people undergoing surgical procedures and having chronic implants can have a degree of predictability that the thing is going to work for them.
Thank you, gentlemen. Cynthia.
Hi there, I'm Cynthia Templeton. My son sustained a spinal cord injury about 20 years ago, and we subsequently founded an activity-based training gym in New Jersey called Push to Walk. I'm also a core member, founding member of a group that's an association for all of the centers like Push to Walks around the country. Several people in that group are here today, including Matthew is involved with us as well. But my question is, with the ARC-EX, how do centers like Push to Walk and those around the country be considered for the clinical use and the subsequent home use for our clients? Because we have all the people who want to use these kinds of devices. So how do we be instrumental in bringing this technology to the people who are looking for it?
Well, thank you for your question. We cannot market the device until it's FDA cleared. So that's why you don't have anybody knocking on your door today. But at the appropriate time, we will be putting an organization of people out there. Our expectation is that the majority of them will be former physical therapists who maybe have some experience working for companies like ours, and they can help make the device available to you, as well as assist with your clinic's adoption and use of it within your workflow. There is a guy from ONWARD there in Atlanta named Blake Pokris. So please introduce yourself to Blake.
In the back.
Again, and he'll take your name. Again, cannot market it to you or promote it to you, but he'll take your name, and at the appropriate time and in the appropriate way, I'm sure he would be very pleased to get in touch with you and have this discussion.
Can I add one point here too? So just to remember that the results in the Uplift study were very encouraging, but that was with functional task practice that was designed by a physical therapist with experience. And so, what we're talking about creating is a favorable neuroplasticity. And so there will be some need, at least, in the beginning of the design of the program for an individual, to have some type of skilled, experienced therapist help design what that exercise, if you will, program is going to look like.
Thank you again, gentlemen. One more question.
Hi, I had a question more focused towards Dr. Guest's talk. I really thought it was interesting that you mentioned including the 5 non-responders in the at-home trial. And I wanted to know if you could go a little more into why you guys chose to include non-responders and if you saw any noticeable enhancements or improvements after the at-home study versus the in-clinic study.
I think the first part of the answer, and Dave may correct me if I'm wrong, is that the results of the Uplift study had not been examined to determine who was a responder or not a responder before the home study was conducted. So I think that it was incidental that there were 5 people who didn't meet the technical responder criteria who participated in that study. People have talked about all sorts of things that they've experienced during their period of ARC-EX stimulation. A lot of people talk about a reduction in fatigue, and other things that we really didn't get into today. So I think that the papers really report based on what were pre-specified outcomes, but people also reported a number of other favorable experiences, in particular, this issue of fatigue improvement.
And I would say as well, Dr. Guest, that we didn't conduct the study to show necessarily continued gains. It wasn't powered to that, for that, as you mentioned, but instead we wanted to gather evidence and observation to demonstrate that the device could be used at home and didn't need to be used in the clinic, just from an operational perspective, that people with injuries could in fact use the therapy in the home setting. That was the goal. It's nice that we did get some data out of it, as you showed. And moreover, we did see, and I think you can speak to this better than me, that some of the Uplift study participants were only beginning to show effect at the end of the 2-month stimulation period. And so there was some hope potentially that extended or prolonged exposure to the device would be beneficial for them.
Yeah, and also, there was just briefly, there was a question in the chat about maintenance therapy and a requirement for that. I have to say that I don't think we know enough yet. I think that the results from the gap between the Uplift and the home study would suggest there might be a benefit to some type of ongoing exposure to the therapy, possibly at a significantly reduced sort of frequency of interval frequency. But that remains to be determined.
Thank you, gentlemen. Appreciate the presentation. And again, we missed you being here, but grateful that you were able to virtual in. So thank you.
Thank you.
Thank you very much.